The language that we use matters. It makes a difference. This was a study of 600 doctoral level clinicians, and all they did was give two different descriptions of the same patient. And in one, the same clinical scenario, in one they described the person as a substance abuser, and in the other they described the person as having a substance use disorder. And then when queried about what their clinical response was to these patients, for the patient who was labeled as a substance abuser, the clinicians were more likely to say that that person needed punishment, can self-regulate but chooses not to, can control his drug use, was blamed for drug use, and was considered a social threat. And then when that same clinical scenario was labeled, that person was labeled as having a substance use disorder, those same clinicians said that person needed treatment, that their drug use was out of control, that was out of his control, that drug use was not his fault, and that it was a problem that he needed help with. So what we even write in the medical record makes a huge difference. There's also a study, I think out of Johns Hopkins, that looked at language around sickle cell pain crises. And in that study, it was of medical students and residents, and they used the two same clinical scenarios, but in one, the language had stigmatizing language. So they used a lot of quotes, and I think we do this, you learn this in training, right? Like you can put quotes around something to make it seem like the patient isn't really telling the truth or that you doubt what they're saying, right? So there are lots of quotes in the stigmatizing about their 10 out of 10 pain. That person was labeled as a frequent narcotic user in the stigmatizing language. And when the clinicians, the students, and the residents were asked about what their treatment plan would be, the more stigmatizing language in the medical chart, their treatment plan that they developed, they used less pain medicine to treat that person's pain. It really directly impacted the plan of care that they were less likely to admit the patient for a pain crisis. So that language really made a difference in terms of the actual treatment that patient was going to get. And interestingly, the further the students and the residents got in their training, the more likely their plan of care was changed by that language, which I think says something about how we train our residents and our providers. So there are certain words to avoid, and there are better choices. So in terms of language and addiction treatment, we want to avoid words like addict, abuser, junkie. A better choice would be a person in active addiction, a person with a substance use disorder. I think always keeping front and center that this is a person first. They're not defined by their medical illness. Avoiding the word abuse. Better choices would be misuse, problem use, or risky use. Something I see all the time, and I really had to evolve my own personal language around this, clean versus dirty when talking about urine drug screens. A better term is a negative urine drug screen, a positive urine drug screen, or a substance-free drug screen. That clean, dirty dichotomy really puts a value judgment on that test. Habit or drug habit, another word to avoid. Better to use medical terminology is substance use disorder, active addiction, alcohol and drug disorder. Words to also avoid: replacement or substitution therapy when you're talking about medication-assisted treatment. That perpetuates the idea that medication-assisted medication-assisted treatment is substituting one drug for another, which is a misconception that makes it really hard for people to engage in treatment that they need that can be life-saving for them. Another word to avoid is user, and instead a better phrase would be person who misuses alcohol or drugs. And the phrase born addicted is also very stigmatizing, so a better choice could be an opioid-exposed newborn or an infant with neonatal abstinence syndrome. And there are words that work, so you can say addiction, addiction-free, addiction survivor, addiction disorder/disease, medication-assisted treatment, misuse, patient. Fundamentally, that's who we're dealing with, is patients. Persons or people with, and then remission is another word. And then in terms of talking about babies, and my pediatric colleagues, feel free to shout out some other, if there are any other words to avoid in terms of babies. But the idea of ever calling a baby a junkie, born addicted, I hear that a lot from patients saying that with previous pregnancies that they had a baby that was born addicted, so we do a lot of reframing of that. Babies can be opioid exposed or substance exposed, but they're not born addicted. I also hear a lot of talk about babies suffering, and we hear that a lot in the press also, and a better choice of phrase may be experiencing withdrawal symptoms, a less stigmatizing way to frame that. And so I have a couple scenarios, and then I would like to ask for some brave volunteers to help rephrase these quotes. So this one is, "Hi, my name is Dr. Smith. You were referred to me because of your drug abuse. I noticed your drug screen from your OB's office was dirty. How long have you been an addict?" Brave souls. Anybody? Anybody? Yes.
Hi, my name is Dr. Smith. You were referred to me because there's some concern about maybe your drug misuse. I noticed that your drug screen was positive from your OB's office. How long have you been using?
Great, much better. Okay, so this one is maybe from a more like pediatric perspective. So the symptoms your baby is having are because your baby's addicted to buprenorphine. Because you use this drug during your pregnancy, your baby will suffer. What else did you take during your pregnancy? Dr. Murad.
Okay. So I think the thing I would rephrase, babies, again, cannot be addicted. They're not going out and seeking to have opioid use. That's just not possible. So what I generally say to families is, I'm so glad you entered treatment. Your baby may have some withdrawal symptoms. Let's talk about what you're seeing. And reframing it so they are talking with me about what they're noticing. So that it's not just me saying your baby has some jitteriness or increased tone, because most of the time the parents are worried. And so having them engaged and telling me what they're seeing is a better way of going about it. We do have to ask them what they have taken during pregnancy, because sometimes it's caffeine or tobacco or other substances. But I think you have to do that in a very open-ended way. So tell me about your pregnancy, tell me about just your life in general, what else is going on.
Right. Right. So this one, "Hi, I'm Jane, your postpartum nurse. On a scale of 1 to 10, how would you rate your pain right now? Since you have a problem of using drugs, we need to avoid giving you pain medication. It's going to be difficult to treat your pain, so you're going to need to tough it out." And this is, we laugh, but this happens, right? How many times have I had a patient who's had a C-section who has not been given pain medicine adequate enough given their baseline tolerance and the hyperalgesia because of, so how would any nurses out there want to tackle this one?
So we actually had some issues with some pain control in our facility a couple of years ago. We kind of tried to refocus it on, we know, some of the medications you may have been on during your pregnancy, it's going to be difficult for us to treat train, but we're gonna work together as a team and do everything we can to make you as comfortable as possible.
Yeah, so important.
We embraced it in that aspect, and
Yeah.
I think we're doing better.
Yeah. So, and making clear that this is a conversation. Like, this isn't like a one and done, like this is the only option, but we're gonna be touching base and it's gonna continue to be addressed. And then the last one, so this is giving a handoff. So, hi, this is Sarah. I'm the midwife over in clinic. I'm sending over a patient for elevated blood pressures. She's crazy and smokes crack. She says she's contracting. She looks pretty comfortable to me. So right, so we're not talking to a patient here. We're talking, and I think that in medicine, we do some things to protect ourselves, right? We do, like, there's like dark humor and gallows humor, like in the ER, if you've ever worked in the ER setting, I mean, like that's like some like dark stuff that people joke about, and that's protective. Like, there's a reason for that, like, because this kind of work can be emotionally draining. But the point for this quote was how we present a patient when we're doing handoffs is going to affect their care. So if this person said instead, like, I'm sending over a patient for elevated blood pressures to rule out preeclampsia, she has a history of substance use disorder, and she is complaining of contractions. I've put her on the monitor over here, and her contractions are irregular. I've checked her cervix. It's long, thick, and closed, so I don't think she's laboring, but we'll need further monitoring. And so that's just the facts without kind of the extra embellishment and value judgment. So in summary, no one wants to be defined by their disease, whatever that might be. Only when we treat patients as individuals can we optimize outcomes. And ultimately, what we say reflects our underlying beliefs and opinions. And what sometimes happens is that stigmatizing language is used to distance us from our patients. And so sometimes when we see this happening, it may be an opportunity to check in with ourselves. Are we experiencing burnout? Like, what is serving us? Is this language serving us?
Honestly, if we're not having an effect with what we're saying, what's the point of saying it? So you ended the talk by talking about burnout, which I feel like as providers dealing with difficult situations, which we all do, burnout is going to happen. So motivational interviewing is wonderful because if you can really embody the spirit of it, it actually decreases the feeling of provider burnout. All right, so I have no disclosures. I'm going to start with this definition, and then I would love to, this is going to be very interactive, so to find out from the room who knows about motivational interviewing and what are your thoughts. So from the founders, Miller and Rolnick, motivational interviewing is a collaborative conversation to strengthen a person's own motivation for and commitment to change. So how many people here have heard about the term motivational interviewing or use it in your practice? Okay, a decent amount. So can I have some brave souls to tell me, and you can just shout out, a couple of thoughts, feelings, emotions, actions that come to mind when I say motivational interviewing? I'll start. I said connectedness. So that's one. What is MI? Anything else?
Collaboration.
Yes. Engaging.
Active listening.
You guys can talk for me. Active listening.
Reflection.
I heard reflections. I also heard patient-centered. let me know if I'm saying things that you guys already have heard, because it seems like quite a few of you have at least heard of the topic. So we know that it's evidence-based and so therefore has been widely used throughout healthcare in multiple healthcare and life settings. It was born out of the world of substance use disorder, and since then in the mid to late 90s has been extended throughout all of healthcare. So it's now used for nurses' health partnership and chronic disease management, in addition to substance use disorder, like things for hypertension and diabetes management. Also obesity management, which is how I came into it. So why is it useful? We have to make a couple of assumptions for you to be able to really use MI effectively. So we do know that people, and throughout this talk, instead of saying patients, I'm going to say clients, along with staying away from stigmatizing language. Client is just a more neutral way of talking about the people that we work with, and kind of connotes that it's a partnership together as opposed to a hierarchy. So we know that people, including our clients, do what they feel is necessary or important in their own lives, and that's not always going to be aligned with our own goals as healthcare professionals. So while we might be the experts when it comes to treating illness and counseling on general wellness, we often really don't know what's best for our clients at every moment given their life circumstances. So these are important assumptions to hold in order to really use MI effectively. On top of all this is just the assumption that people generally will do what's best for their life, and no one really wants to do anything that's going to be detrimental to them intentionally. So we're always striving to do the best, but what that best looks like for me may not be what you intend for me. So if you believe that people are always trying to do their best when they give you an explanation or they seem to be difficult, holding on to that theory, it makes it easier to have a conversation. So using MI is great for developing a collaborative partnership with our clients, and it's important to recognize that we both bring expertise to the encounter. All right. Additionally, it allows us to gain insight into what clients perceive as happening to them, which is really important if we're going to have any discussion about change, and what they feel is most important. And that's going to be what they're going to act on first anyways, so you might as well start there. MI builds a therapeutic relationship that's fundamental to engaging, empathizing, and ultimately can lead to shared decision-making regarding treatment for things like substance use disorders, obesity, etc. All right, so this is where it gets fun, and I'm going to need a volunteer, a brave volunteer, but all the instructions are going to be up on the board. So let me talk you through it first. We're going to walk a mile in another person's shoes, because what better way to feel what MI feels like than to first feel like what MI is not. Okay, so I'm going to be the speaker in this role, and I'm going to choose a topic personal to me, a true topic, because that's how it worked best, that I've been wanting to change, I need to change, I should or ought to change. I've been thinking about changing, but I haven't changed yet. So this is basically something I'm ambivalent about. And then I'm going to need a volunteer to be the persuader. They're going to come up here with me and try as hard as you can to convince me to do the following things. And you just literally have to just follow the directions on the screen here. So explain why I should make the change. Give me at least 3 specific benefits that would result from making the change. Tell me how I should make the change. Emphasize how important it is for me to make the change. You might have to, tell me about the negative effects in order to really convince me. And then finally finish with a statement that just says, Tamison, you need to make this change. It's just 2 minutes. I don't even think it'll take us 2 minutes to go through this. Can I have a volunteer? Tell me your name.
I'm Anna.
Yeah, Tamison,
Hi, nice to meet you.
Awesome. All right. So you're going to be my persuader. This is going to feel unnatural because we wouldn't all be sitting here if we didn't really try not to do this. But try really hard to be this person, okay? So I am gonna tell you that I really need to start exercising. I had a baby 14 months ago, and I've gotten through the initial period of kind of getting used to being a mom and going back to work. And I've lost some of the baby weight, but I still need to lose more. And some days I think, I'm gonna do this, I'm really excited, but she wakes up in the middle of the night, I'm tired in the morning, work's really busy, so I'm not really sure if I want to make the change.
Well, Tamison, I'm going to tell you why you should make this change.
Okay.
It is going to give you more energy and make you feel so much better if you can get in there and get 30 minutes of exercise 5 times a week. It's going to help your mind stay clearer, and it's going to help reduce any kind of depression. It gives you those endorphins and helps you feel better. Your body's going to get in better shape, which is going to make you feel better in clothes and give you more energy to go home and take care of that baby.
Yeah, you know what really gives me energy? Sleep. And if I have to choose between working out and sleep, I'm going to choose sleep. That's been part of my problem.
I understand. I would encourage you to try to figure out a way to have both. Maybe you could put it in your schedule and set something up when you have that support person there to help watch the baby, even if it's just going to take a walk outside so you don't have to go far. So let's try to schedule it and make it a priority.
I completely agree, but you know what? My husband travels for work Monday through Friday, so I'm the only person to take care of my daughter throughout the week. So I drop her off at daycare, I go to work, I come back, I pick her up, and it's just me and her all day. So I don't even have anybody to watch her for me to go work out.
Okay, well, let's incorporate the baby in this exercise. Let's push that baby in a stroller and get your carrier and just take that baby with you and look up YouTube videos on some mommy and me exercises. But I would encourage you that it's really important for you to invest in yourself to help you be a better mom and take better care of that baby.
Okay.
And if you don't, I'm afraid you'll find yourself being more exhausted and more sleepy and not feeling as good about yourself as you could. So, Tamison, I want you to do it. I want you to exercise. How about we start with 4 times a week for 30 minutes and you just take that baby for a walk in the stroller.
Okay, I'll do that.
Okay.
Thank you.
Okay, good.
Thank you, everyone. I was ambivalent in this encounter. And that's a normal place to be. That's where a lot of our clients are going to be. That's when we have mixed feelings or contradictory ideas about something. So a synonym for ambivalence may be doubtful, you have indecision, you're uncertain, you're hesitant. So when you encounter someone who's ambivalent, they may seem frustrating, like they're resistant, that they don't want to change, but really what's happening is they continue to provide themselves with reasons for making the change and for reasons against making the change. And MI is really great because it can provide a discrepancy, if you use it appropriately, for the person who's ambivalent to start to move towards the direction of change. So we do know that change is a continuous variable, and the trans-theoretical model by Prochaska and DiClemente is actually really fantastic and fundamental to motivational interviewing, has recognized 6 stages for change, and the understanding that people can go back and forth between those stages, sometimes within the same moment. So here are the 6 stages of change. It's really small, so I have it on the side here. As I'm going through, I'd love for you guys to tell me what stage was I in that encounter. So the first is pre-contemplation, and that's limited recognition of the behavior. It's posing a problem in relation to its advantages. So there's no perception or need for help. There's contemplation is the next stage, and that's weighing the pros and the cons, but not yet ready to change. Determination is the 3rd stage. We're preparing to make a change, but not actively committed to changing. The 4th stage is action, where we're making active efforts to change behaviors, but not able yet to sustain those changed behaviors. 5th is maintenance, where we're making active efforts to sustain changes in behavior. And the 6th, it just says recurrence up on the slide, but actually it could be recurrence/termination. So when recurrence is the 6th stage, you can make it all the way through maintenance and then end up kind of falling back to the old behavior that you've been working on changing. By the way, this is a natural kind of trajectory of how things can go. Or you can make it all the way to maintenance and actually resolve the behavior enough that there's very little concern for the recurrence of that behavior. So which one of these was me, do you guys think, in that last interaction? Yeah. I was in that contemplation, I am in that contemplation state. Still weighing the pros and the cons, but not quite ready yet to change. Did you feel like there was any movement in our discussion towards determination? No, okay, keep that in mind. So inherent to practicing MI is understanding of the MI spirit. And that is that motivation to change is elicited from the client, not imposed on them. So when we understand that, it makes everything much easier. You can become a little removed from your expectation of what you want from the visit and more curious about what brings your client in and what their desires are. So it's the client's task to articulate and resolve ambivalence, and persuasion is not effective in resolving ambivalence. It's composed of 4 different aspects. We have compassion, which is keeping the client's best interest in mind. Acceptance, which is honoring the client's right to change or not to change. Partnership is basically the biggest part of this. So you want to avoid the expert role and really be a collaborator with your client. And then evocation, almost as important, is drawing the ideas for change out from the client. Why? Because they are the expert, not us. So what makes MI not manipulative? I just shared with you that we have this wonderful counseling strategy where we can take somebody who's in one stage of change and move them to the next. And we're going to use the spirit, which is up on the board here. These 4 components can actually really help you move somebody from one part of change, from one behavior state to another. So MI can easily become manipulation if you don't embody the spirit, if you don't make it collaborative, a partnership, honoring the person's desires to change or to stay the same, and really asking for their input. So MI is really about assessing clients' motivations and exploring ambivalence or resistance so that they're better able to make decisions for their own lives. So you really do have to be a curious participant in the encounter with your client. It's not meant to be used to convince or motivate clients to change their ways for what we want for them. Now, as a provider, I know this is hard. We are mandated to share certain pieces of information. That's what we did. We, have a Hippocratic oath. However, we are a medical professional, we have information we need to share. That's what we do. So I'm not saying that we shouldn't share that information, but I'm saying we can use MI to do it in a way where we're not trying to change what the client actually wants, but can still provide that information for them to at least consider doing at a later point. So in order to practice MI, there are some core skills. It's kind of core to any kind of counseling strategy, but in MI, we use this to kind of create almost like a dance with our clients, to kind of walk with them towards a direction of change, or to explore why they don't want to change and they kind of want to stay where they are. So the core skills is known by the acronym OARS, and that's just for the first letter of each of these core skills. So we have open-ended questions, affirmations, reflections, and summaries. Has anybody heard of these core skills before? Okay, some yeses, some nos. All right. So, but you've all heard of open-ended questions. Affirmations, more or less familiar with? Okay. Reflections and summaries. They're kind of like well-known concepts. So for our open-ended questions, and these are simply questions that can't be answered by yes or no, why are we asking open-ended questions? Because we want our client to feel comfortable sharing their thoughts about potentially sharing their behavior, changing their behavior. So now that we know, it's really important for us to be curious about what our clients' motivations are. It's kind of, maybe a difficult thing to do. You're a stranger, they're a stranger on the first interaction. How do you engage them? You ask that open-ended question to find out more information about how they feel about being with you today, what are their desires and motivations for changing, or how do they feel about their current behaviors. There are 4 types, and you can kind of use it throughout the visit to kind of help move things along. So in the beginning, you may want to ask about disadvantages of not changing or ask about advantages of changing, just to open up the conversation, get a dialogue going, and engage your clients. Then towards the end, if things are moving well, you may move into talking about asking confidence with being successful on changes that have been discussed, and just even asking about the intention to change. Affirmations are really important for building clients' self-esteem and self-confidence. So these are positive reinforcements and statements of a person's behavior that deserve recognition. And the pride that the client feels from the recognition can lead them towards change in a positive behavior. Reflections, these are statements that repeat, rephrase, paraphrase what the patient has said. And this is really important for engaging. It allows clients to feel heard. So when we're using reflections effectively, the client should be nodding along with what we're reflecting back to them that we've heard them say. Reflections, when used well, you will know, because the conversation is more the client speaking and you reflecting than it is us speaking and the client nodding their head. So it's essential, as I mentioned, for building empathy and rapport, and builds trust and can positively impact the client's desire to change. So you can use reflections for anything. I can say, man, it's really cold outside. And a reflection can be, you feel like the weather should be warmer, right? That could be a reflection. And so in a conversation that you're going to have with the client, as I mentioned, as providers, we have a goal in mind for each of our encounters. You want to selectively choose statements that the client is making that might be an argument towards change, and take those to almost amplify and reflect back. So you're still acknowledging everything the client is saying, but you're amplifying those statements that might be in the direction of change, and in so doing, trying to move the conversation in that direction, or getting feedback from your client to let you know why they're not interested in changing. And summaries do a similar thing. They allow clients to hear their own reasons for change, and can be used to ask a client where they stand on wanting to make a change. So at the very end of the visit, if nothing else, you pull out all what you've heard as statements towards change and statements against change. You kind of put it together in a bouquet and paraphrase it back to your client and allow them to clarify for you where they are at that point during the visit. Someone had asked earlier, practically, how do I engage with the client when I have information I'm mandated to share? So there's this concept, elicit, provide, elicit, that's used within MI that's actually pretty effective. It's a practical approach to providing medical and technical information to clients while still respecting their autonomy to choose to change or not. So you start first with elicit, and this is where you're going to use your open-ended questions. You're going to draw out the client's existing knowledge and interest about the topic to be discussed. And there's an example on the next slide. Or permission, ask for permission to share information about the topic. Then you're going to provide information. And you can provide information on the topic that you want to discuss. You can provide affirmations to build up your client's self-confidence and self-worth and empower them. And you can provide statements that show that you support your client wherever they are in their desire to change or not. And then you're going to elicit one more time to get reactions from your client about how they felt the encounter went, whether or not they want to change, or if they have any other questions. And it's really very powerful. Most people, when you ask, can I share some information with you? Even if they were mandated to be with you and didn't want to be there, most people will say yes. At least as an opening. So here are some examples about, what kinds of questions would be a good initial elicit question. So you can start off by saying, what do you know about, in my case, it would be nutrition or eating healthy. Or what do you know about why you're mandated to be here today? May I share with you some information about, insert whatever it is, the topic that you want to discuss. You start off there, and then this allows the client to speak. And you don't just ask one or two questions. You really want to ask questions that allow you to get an understanding of where your client is at this time in the visit. Then when you understand that, then you can provide information, and you can say, I'm here to help. I have some information that I have to share with you. I'd like to share with you some information about managing high blood pressure, or how to take care of a baby with NAS. So then after you've provided information, the last thing you're going to do is elicit from your client how they felt everything went and whether or not they have any further questions. So some examples are, is there anything else you'd like to learn more about, or how do you feel about this information? And this seems really simple, but it's a really nice way to very quickly use the skills of MI in a real way in your practice. Let's talk about a few different things. For the care of your children, I get a sense for the goal where we'd like to head, which is to keep them with your family and allow you the space to kind of get the goals and the dreams that you want to be able to protect them. What's one step in that direction? Maybe today they can't all go home with your parents, but what's one step that puts us closer there? How can I help with that?
I need to fill out the paperwork. I need to look at what type of school would give me an opportunity to have or create to get a good job.
Okay.
Like what could I do? What type of certification could I get that I could be good at? Because I don't like school. I really don't like school.
Okay, that's fair.
But I want to do something that I would be good at. I'm not sure what I'm good at right now.
But you're sure you're good at something. I mean, you couldn't even want to do something you'd be good at if you thought you weren't good at anything. There's something out there that you feel like you could be really good at.
Yeah, I think so. But I don't know what that would look like. I don't know if it's my love for talking to people or my ease with other people's kids and not mine.
Right.
Or just how much I love my community. I would love to do something that helps me to get better and to be able to work with other people. I like working with people that I do know.
Okay.
I'm just not sure what
With
job that is.
No, that makes sense. So how do you use us to help you figure that out?
I don't know how to research a lot of that stuff.
Okay.
But having someone research some things, and maybe we could sit down and look at some of the different type of schools and the type of things that are needed and required for me to do the type of work that we decided I might be good at.
I would be very happy to do that with you, especially if we can find a couple of schools and a couple of programs that make you very excited. School isn't easy, but it's doable when you have a goal in mind. So if you're excited about your goal, then you'll stick through it and do that thing that you know you're good at, that we're not quite sure exactly what it is just
Right,
yet.
we don't know what it is, but we know it's something.
Yes, it exists.
But if you can do that for me, because I'm not good at that yet. But I know one day I will be.
Absolutely.
Yes.
And I'm here to help you get there.
Thank you for that.
So what about in taking care of your children? How can we help you? Sometimes it's just finding a good pediatrician, somebody who really understands your needs and what you want for your kids, and who is responsive and respectful and really walks hand in hand with you, kind of helping you take care of your kids. Then at least you know they're kind of developing as they need to be.
I would like my pediatrician to be able to see all of them at one time. I know that's hard as well, but the thing is, it's a lot to have this amount of children, and you have to run back and forth to the doctor. I'm trying to find a way to get most things done at one time. So if they can help sometimes to sort of coordinate all of that, that would be very, very much easy. And also help me find childcare, because I can't go to school without childcare.
Right.
Maybe it'd be easier for my parents to travel back and forth if they had the money to come back and forth. They on a fixed income. They can't take care of my kids and take care of themselves. So I would love help on that, just to help us from having to do all this riding around and traveling
Yeah.
Being able to get some extra support with that would be great. And making sure we can all sit down at one time and get all the immunizations, whatever you guys need to be taken care of with them. I don't have to make 15 trips back and forth.
No, that makes sense.
Yeah.
It may be hard to get all kids seen at one time, but if that's your goal, then we can look out for pediatricians and we can research pediatricians who'd be willing to, so it's 6 kids total, but at different
Yes.
ages, they don't all have to be seen at the same time anyways. Some are going to be coming for yearly checkups, some are going to be coming for monthly checkups, and maybe we can group them that way.
Yes.
So it might not be 1 visit, but it could be 2, where you really can focus on, it might even be nicer actually, then you can focus on, 3 of your kids and their health and not all 6. Does that be a little overwhelming? It'd be great for the visit.
It's
in and
always
out.
overwhelming. Always overwhelming. But I do hear you because up until now, it's been several visits.
Right,
And
yeah.
somebody got to miss because I can't get back and forth.
You're very excited about the birth of your new child.
I am.
Yeah, and there's a lot of exciting things to happen in the future. You're really looking forward to how you can progress in your career to provide a better life for them. But you
Yes.
recognize that you're going to need some support.
I am.
And you'd like to keep it within the family if possible. Because that would
be
give you the
really
most
helpful.
peace of mind.
Yes.
And then if we can find you a pediatrician that can kind of adjust to your lifestyle to allow you to have multiple kids seen in one visit, who really respects and honors what you're doing, that you feel like you can relate to, you can make it to those appointments. And if we can get you rideshare or a transit car, you can also make it to your own appointments.
That would be really great
Do
if we
you,
can do that.
do you feel like that would put you in a good space to set you up for success? Is there anything we're missing?
I don't know if I would say set me up for success, but it would
Okay.
get me on the, I'm just trying to do better than what I've been doing.
Yeah.
I think I need support because it's hard to be a mother. And it's hard trying to be a good mother.
It is. It sounds like you have really good support at home, though. That's part of the reason why you want your kids to stay within the family.
I have support, but I'm
Not
happy.
really good?
I'm happy to be able to know how to ask for support as well. Where they can't help me,
Okay,
you
understood.
guys can.
With childcare, finding the pediatrician, helping with the ride share and things like that.
Yes.
All right, so I think the first step is getting somebody in here so we can chat about how to get you better access to transportation, getting you a list of pediatricians, and then kind of make a follow-up appointment maybe within the next week or so to see how things are going and check in with you.
That would be great. And make sure you Google all those different programs about helping people so we can start applying for schools.
Absolutely. And then
Thank
we'll meet up again next week.
Yes.